What's going on, guys? Tony Maritato here. And in this video, I want to talk about an old topic that needs to be brought back: how you understand the difference between covered and non-covered services, specifically related to a Medicare beneficiary who is seeking cash-based therapy. So this is a deep topic, far more than I can cover in this video. I want to show you some of the Medicare literature. I want to show you one of the local coverage determinations, one of the local coverage policies. I'm going to pull an example about total knee replacement. I've used this example before, but for those of you who haven't seen it, it's worth watching. I'm going to show you CMS Chapter 15, the Medicare Benefit Policy Manual, Section 40, on why I think some kind of workarounds don't really make sense to me. And then we'll talk briefly about kind of what this means for you as a cash-based therapist who does not have an association with Medicare. So let me see if I can share my screen, and let's open some documents. So this is a local coverage determination for outpatient physical therapy. And the section in this that I always reference, let me see if I can find it for us: total knee replacement. Okay, so this is specifically talking about joint arthroplasty. I'm going to zoom in and make this big. Give me just a second. I'm in the clinic. I'm waiting for my next patient to come in, but I apologize, but I'm just going to read because these are Medicare words, right? For example, as part of the initial therapy program, following a total knee arthroplasty, the patient may start a session on an exercise bike to begin gentle range of motion activity. We all do it. That's what I do. Initially, the patient requires skilled progression in the program from pedal rocks to building to a full revolution, perhaps assessing and varying seat height and resistance along the way. Okay, so as a therapist, how many visits does that require, right? Well, it's going to be different. It's going to be different based on patient, based on complexities, based on other complicating factors. Did your patient with the total knee replacement have an infection? Did they have wound healing issues? Do they have cognitive issues? You know, are they at risk for a heart attack, for a stroke? Like, are you monitoring vitals? All of these things come into play. For me, in my practice, the vast majority of my clients walking in the door are independent. They're living independently. They're fully functional in the community. They're managing their finances. They're cognitively intact. If I tell them something, they remember it the next session. Do they remember it perfectly? No, but good enough, right? That's my typical clientele. Once the patient is able to safely exercise on the bike, no longer requiring frequent assessment and progression, even if setup is required, the bike now becomes an independent program and is no longer covered by Medicare. So pull that example out and let's have a conversation about this. I'm going to grab, see if I can grab full screen here. Okay, so if you're in the cash-based private practice world, right? I started cash-based. I was in Siesta Key in Sarasota, Florida, very affluent community, beachfront properties. I started as a personal trainer. We moved into outpatient physical therapy. But the idea is the clients that were coming to see me were really not highly medically complex clients. They were playing golf and tennis. They were just coming in with aches and pains. Even my post-surgical cases, if I had a patient that came in status post total knee replacement, they were generally living and active independently before surgery. They had surgery. Now they need my services as a physical therapist. But once I show them how to use the recumbent bike, how to set the resistance, how to turn it on, how to get your feet in the pedal, how to start rocking, they understood how to do it. And if I showed them twice and maybe a third time, there wasn't a need for a fourth time. I think the population that is looking for cash-based services, right? This is a high functioning, high level population. These aren't necessarily always medically complex individuals. So my hunch is the majority of the services that they're seeking, while they're looking to have a physical therapist deliver the service, delivery of the service by a physical therapist, occupational therapist, speech language pathologist, in and of itself does not make it medically necessary and does not make it a covered service. And so as we flesh out this conversation, what I always encourage is kind of two things. One is understand the demographic. Just because we've been ingrained with the idea that if it's not medically necessary, I can't do it. Well, of course you can. That's the whole reason to move to a cash-based practice model. So you have the freedom to do whatever you want to do as long as you and the patient are in agreement with it. So it doesn't have to be medically necessary for a physical therapist to deliver the service. Hence, it's not always a covered service. That doesn't mean it doesn't require skill. It doesn't require knowledge. That doesn't mean it doesn't require expertise. It does. You might have advanced certifications. You might have advanced knowledge over 20 years of practice that absolutely would benefit somebody. While the condition might not dictate medical necessity, it is beneficial. Another really common one in my world is manual therapy. I'm not a certified manual therapist, but I touch most of my patients. I do some form of soft tissue massage. I do some form of touching with my hands and my fingers. That being said, my approach to manual therapy is your shoulder hurts. I'm going to rub it. It's going to feel better so that we can exercise more effectively. The massage, the touching, the rubbing that I'm doing as a clinician is not medically necessary in most cases. And Medicare has some great examples of when manual therapy may be considered medically necessary. In my situation, most of the time it's not. And if it is, maybe it's necessary for 1 or 2 sessions. It's not necessary for 12. Right? And Medicare has guidelines. The MAC has put out certain kind of expectations for massage. I think it's 6 to 8 visits. Manual therapy is more visits. Neuro-re-ed, like you can find these resources anywhere out there if you look and know where to look. That's where I come in. But anyway, so the point of this is to say, look, you have a high functioning client. They come in with neck pain. If it's been determined that there are no red flags, they're not having bowel or bladder function issues, they drove themselves into the clinic, they dressed themselves, they bathed themselves, they're, cognitively and they're intact. They want to swing a golf club better, but they can't because their neck hurts. To me, and this is important, after you've ruled out all the possibility of true medical necessity, that's a self-pay client. That is performance with pain. Pain in and of itself does not make something medically necessary. Pain resolution is not a covered service. I did a Google search through CMS Chapter 15, Section 220, and I think 230. The word pain comes up 1 time, and it's not associated with anything. It's referencing something else. So I want you to understand, like, pain is an impairment. Pain is a symptom. Medicare is paying for return to function. Medicare is paying for reducing or slowing the functional decline. Medicare is paying for very specific standards. And if you look at the published standards, you can start to create your own way to determine, hey, is this really medically necessary? Don't confuse medical necessity with your knowledge base. Don't confuse medical necessity with expertise. They are completely separate. They have to maintain separate categories because too many clinicians think, well, I've got 20 years of knowledge and history and con eds and special certifications, and it doesn't matter when it comes to medically necessary services. We have to understand their language, Medicare's language on this. So that being said, let me just take you into section 40 real quick. Let's jump back into my computer. There are absolutely some advisors that are saying, well, the patient has the right to, you know, healthcare. Hang on, I can't talk and type. And so if the patient refuses to allow you to submit a claim to Medicare, then you're no longer in violation of the mandatory claim submission law. Okay, I'm not going to argue with an attorney. I'm not going to argue any of those points. This is the Medicare Benefit Policy Manual. Section 40 is the information you need to understand regarding opt-out providers. We are not opt-out providers. But more important, if I take a look at this paragraph right here, and I'm going to zoom in again so you guys can see it a little bit better. But basically, the only situation in which a non-opt-out physician or practitioner or other supplier is not required to submit a claim to Medicare for covered services is when the beneficiary or beneficiary's legal representative refuses of his or her own free will to authorize the submission of a bill to Medicare. Okay, awesome. I feel like everybody stops reading right there and they're celebrating and they're cheering. Here's the problem. However, there's always a but. However, the limits on what the physician, practitioner, or other supplier may collect from the beneficiary continue to apply to the charges for the covered service, notwithstanding the absence of a claim. So even if you take the route of saying, hey, I have no affiliation with Medicare, I'm physically unable to submit a claim to Medicare, you're going to give a super bill to your client. The client's going to give that super bill to Medicare. Medicare is going to come back to you to say, why didn't you submit a claim? You can't submit a claim. You're going to say the patient refused of their own free will to allow me to submit the claim. Doesn't matter. You're still bound to the allowed amount. If you're not going to collect your full cash fee, why not just join the Medicare program? Like, there's no benefit to not being contracted with Medicare and going cash, because you still cannot charge more than the allowed amount for a covered service. But just because it's exercise delivered by a therapist does not make it a covered service. Just because it's a specialized manual technique delivered by a therapist does not make it a covered service. So I'm coming full circle again to say, you have to understand, are you providing truly medically necessary covered services under the Medicare designation description? We know that dry needling requires the skills of a therapist. We know that dry needling requires advanced certifications. We know that dry needling requires specialized knowledge. It's not a covered service. You can provide dry needling to a Medicare beneficiary for a self-pay rate because it's not a covered service. That doesn't mean it doesn't require the knowledge of a therapist. Use that as your example along with the Medicare guidelines. Look at the Medicare examples. Look at CMS Chapter 30, talking about an advanced beneficiary notice and how you decide when an ABN would be used. Keep in mind, an advanced beneficiary notice is only for contracted Medicare providers who are par or non-par. If you're not contracted, the ABN does you no benefit. You do not use an ABN. I hope I shared some useful resources. I hope I shared some ideas. If you were to come to me privately and say, Tony, so how do I do this? This is my advice. Connect with a contracted therapist. If you refuse to join the Medicare provider network, fine, cool. Don't do it. That's fine. Connect with somebody who's contracted. New client comes to you, they're a Medicare beneficiary. You don't know if they're going to need covered services or not. You say, hey, Mrs. Jones, John down the street is a contracted Medicare provider. I need you to see him before you're allowed to work with me. John does the eval. John determines these are not medically necessary services. John determines that Mrs. Jones just needs to work out with a professional. You are that professional. That clears you to allow to charge cash-based. John gets paid. John gets the Medicare reimbursement. John's not losing anything on his end. And hopefully John has the professional expertise to say, I'm sorry, this just isn't a covered service. Medicare doesn't pay for this. If you look at the top of the advanced beneficiary notice in big bold letters, it says Medicare does not pay for everything. If it did, patients would be getting better beds, better food, better sleep, better everything. They don't. Medicare has standards for what is a covered service. All right, guys, I hope that was helpful. Let me know in the comments if you have more questions about this. Let me know in the comments if you're still confused about something. I will go out and find a couple of the other articles that are published, written by attorneys who really kind of shine a light on saying, look, we don't know. It hasn't been tested in court. I don't want to be the one who tests it to get a final answer. So I'm going to always stay on the conservative side. But that being said, you have to understand the guidelines. Guys, have a great day. Thanks so much for watching.